Well, good afternoon. This is Jose Leon from the National Center for Health and Public Housing. It's such a great pleasure to talk to you today. We are going to basically be touching something on non-adherence and behavioral health interventions in diabetes. I believe that the invite had the right slide deck, but now that I'm reviewing the materials, it seems that the blurb is not for the blurb that I was supposed to send for this conversation. So my apologies for that. But the idea is to briefly discuss non-adherence and behavioral health interventions and what health centers are doing to address these issues. First and foremost, I would like to know who is on the call. So if you can introduce yourself, your name, and where are you calling from?
Hi, Joy Mockbee from Tucson, Arizona, from
Hi,
El Rio Community Center.
Thank you, Dr. Magui. Thank you for joining the call. Very nice to hear from you.
Hi, this is Silkia from Ponce, Puerto Rico, Med Centro.
Hi, Silkia. Good afternoon. Thank you for joining.
Hi, this is Stacy Clark, Clinical Quality Manager for the Wellness Plan in Detroit.
I'm sorry, who was that?
Stacy Clark from the Wellness Plan in Detroit.
All right, thank you. Thank you so much for joining us. Very nice to hear from you. Who else do we have on the line?
Hi, this is Andrew and Elisa. We're at Tri-City Health Center in Fremont.
Hi, Andrew and Elisa. Thank you so much for joining us.
No problem. I think we're going to have a couple more from Tri-City joining us shortly.
Excellent. Thank you so much. Anybody else on the line? All right, let's get started. Probably we're going to have more people joining us as we develop today's presentation. Again, thank you so much for your time and your support. We've been talking to HRSA about these diabetes calls, and they are very excited about the conversations and how we are developing all the content and materials. They are very happy to hear all the best practices that we are gathering from all of you. So thank you so much for all your support. And I believe that somebody else has just joined. Hello? All right. Today, as I was reviewing some of the materials that we have, we've been in contact with the American Diabetes Association, and we have been discussing some of issues that they are seeing in primary care. They have a group similar to this one, but their idea is to discuss their standards of care and what they are planning to include in the next year. And one of the issues that one of the members brought up to the discussion was non-adherence and behavioral interventions. I believe that this is a very good opportunity for us to basically talk about this, since all of you are in primary care. And we're planning to share some of the findings and some of the best practices from all of you with not only HRSA, but the American Diabetes Association. They also want to hear from all of you. So as a very quick overview of diabetes in health centers in general and PHPC settings in particular, the number of patients with diabetes and uncontrolled diabetes is increasing. The number of patients with uncontrolled diabetes in community health settings in general is over 32%. If that is the latest data from UDS. 2017 data. And the number of patients, the total number of patients with diabetes is 9.2%. The number has been increasing since 2012. The latest information that I have here on this chart is that in 2012, the number was probably 8.42% for all health centers, and in 2016, the number went up to 8.83%. Whereas the number of patients with diabetes in public housing primary care went up from 80.64% in 2012 to 9.2 in 2016. So as we can see, the number of patients with diabetes and the percentage of patients with uncontrolled diabetes is increasing, and this is one of the reasons why HRSA has made diabetes a priority. Again, the number of patients of uncontrolled diabetes in 2017 was 32%, and that is some kind of background for this conversation. If I'm not mistaken, last time we discussed some of the barriers to successfully treating or managing diabetes. We talked about clinical limitations and clinical inertia and treatment non-adherence, and basically we discussed a little bit about the psychosocial factors, the environmental factors, some interpersonal factors, and some treatment-related factors. And so I would like to see how we can revisit that information, but in the meantime, we can also briefly review some of the modifiable risk factors like obesity and diet, and physical activity. Stress is another one. Smoking and alcohol use is another one. And some of the related conditions like high cholesterol and hypertension. All these are modifiable risk factors. There are some factors that probably are not modifiable, and that is one of the things that we are trying to discuss. So I'm going to stop here for a while, go back to one of the slides, and since one of the two topics that we are planning to discuss is non-adherence, I would like to hear from some of you what are some of the reasons why sometimes patients are not taking their medication or adhering to treatment as is recommended or has been advised by the clinicians. Anyone who would like to briefly tell us what they are seeing or what you are seeing?
This is Stacy from Detroit at the Wellness Plan. I had a conversation with a patient yesterday, and she told me that she basically bases whether she takes her medication or not on, she takes metformin, and she bases her whether she's going to take her medication or not based on how she's going to be out for the day, because of the loose stool side effects. She said that she modifies her medicine based on her day because of the side effects are so bad for her.
Okay, and thank you for that information. Do you is the patient, despite the not taking the medication that has been prescribed, is her diabetes or is diabetes controlled, or she's having some problems controlling diabetes?
She's uncontrolled, and so that's kind of why we went into the conversation about, taking her medication, and she said that because of the side effects that she's had, and she's fairly newly diagnosed, and that's a problem for her. So she was here at the clinic to discuss with her doctor other options for control, just because of the side effects.
Okay, and did the patient receive any new prescription, or the dose was modified, or do you know what the situation?
I will have to follow up with her because I didn't see her following her visit.
All right, and well, thank you, Tracy, for sharing that. Is there anything else that you believe is affecting how patients are taking or not taking their medications? Is there any other issue that you are seeing?
Hi, this is Andrew from Tri-City Health Center. How you guys doing? So we're actually with our HHP program, our Health Homes program. So we deal with a lot of different disease management here, and diabetes is number one within our group of patients that we follow. So we work very closely with our diabetes program here. But what we deal with really is the social determinants of health and psychosocial aspects of their health care. And what we're seeing is, especially out here in the East Bay in California, which would be Fremont to Oakland area, is that we're seeing a lot of homelessness as well as substance use. Mm-hmm. And that's really, and it's common, I mean, to affect the outcomes of their health, but it's really becoming a barrier out here. And it's something that our team has really started addressing and coming up with game plans, whether it be getting access for phones for them so we can set reminders, so that we can set automated text reminders to them. We're walking patients to labs. We just had a patient who hasn't gone to the lab in over a year, and we were able to actually walk her to the lab the other day and get her labs done, which was amazing. And now it's following up with her on an action plan to really get her controlled. But that seems to be the biggest barriers for us, is the homelessness and the substance use. We can come up with tricks and tools and a lot of ideas for patients, but until those issues have really been addressed for them, they don't really want to deal with their diabetes. And it's kind of finding a happy medium for the patient, where we can actually meet them where they want to be and see some results at least.
Thank you. Thank you for that. That is excellent feedback. Do you have any SDOH program, or how are you addressing some of the SDOH issues affecting patients?
So so right now, when we're addressing some of these problems, our Health Homes program, we're integrated in the clinic with our behavioral health program. Mm-hmm. So we have a lot of support, and then our main support really is our diabetes program here at Tri-City Health Center. And we have a new program manager, and hopefully she'll be joining the call shortly. And she could talk a little more about what they're doing as well. We work hand in hand with them. It's really important that all these programs, and with my experience in community health, is really putting everyone together and case conferencing. We all case conference, especially with our diabetic patients. We case conference with the diabetes team, whether it be the front desk, so that they can alert us that these patients are here. Because as we all know in community health, these patients kind of just show up whenever they show up. But we want to capture them right there. So it's really designing protocols. And we've done a lot. I know our diabetes program, I can't speak for them, but they have made tremendous efforts in terms of what they do every day for our patients and how they manage their caseload.
Excellent. Hi, this is Trishna. I'm the Wellness Program Manager, and we are part of the efforts for the diabetes program. So what we do is we reach out to individuals over the phone. We also hold boot camps as well as one-on-ones after the patients are in the clinic. So we try to get them in. We have a panel that we work with to make sure that we're continuing to follow up. If it's been 3 months or 6 months, they haven't had their A1Cs done, or if we make sure they're taking their medication. So we're constantly following up with them. We have protocols, whether we follow up with them in a week or 2 weeks or a month. So we have a lot of efforts reaching out to them. Even if they don't reach out to us, we continue to reach out to the population we have in our panels to continually motivate them to stay on track with their medications. We do medication teaching, glucometer teaching. We go over all their meds. We follow up in a week to make sure they picked up their meds. So we're constantly following with them to just make sure they stay on track.
Excellent. That's excellent information. Now, one of the issues that were mentioned, and I totally agree with Eric, is the fact that you have patients who are homeless patients or public housing patients or patients that basically are on vulnerable and part of the vulnerable populations according to HRSA classification. Now, some of these patients have some issue with health literacy, and for some patients it's very difficult sometimes to understand the recommendations from the clinicians and on those who are helping them to address their disease. Is there anything that you guys are doing to, when you have a patient and you know that the patient is not understanding well the recommendations and indication from different clinicians?
So what we try to do is we bring them in, and we try to catch them mainly in clinic, but the homeless population is something that we haven't in the wellness program been able to touch as much. I know that we do have our vans that do go out to certain locations, and if they can grasp some of that, they put them in our panel if any of them do have any contact information. But far as the wellness team, the chronic care team, it's hard for us to reach out to the homeless population at this time.
Mm-hmm. Okay. Excellent. Excellent. Thank you so much for that. Anybody else? All right. Now, I would like to briefly talk about one of these issues that we've also been discussing with the American Diabetes Association. And they are focusing a lot on clinical inertia. Specifically, sometimes patients are receiving a medication, probably the medication is not working well, and there is the patients and the clinicians sometimes either do not address the issue because time concerns or because there are other issues affecting the patient, and probably it's not easy to switch from one medication to another one, or to switch from oral medications to insulin. I would like to hear from the physicians, Dr. Mogby and Silkia, to think what you to know what you think about this clinical inertia. If there is anything that is an issue in primary care, not only in your health center, but primary care in general.
Hi, this is Silvia from Puerto Rico from MedCentro. I'm not calling it like inertia, but in a follow-up encounter, you only have 15 minutes to be with the patient and do everything in the EHR, examine the patient and during all. I think it's a time management thing. Also, about what you're talking before, we have a problem here with the adherence, but it's a cultural thing because people doesn't want to use the insulin. Because of that timing that's so short for the physician to be with the patient, especially with a diabetic patient that have so many other disease accompanying this disease. We changed our way to treat this patient, and now the physician has 30 minutes with them, so the evaluation could be better.
Excellent. Thank you, Sylvia.
Mm-hmm.
And this is Joy. I mean, I agree that time limitations are definitely an issue, and also patient perception of insulin can be an issue. Additionally, you had mentioned or had a question about health literacy, and I think that also contributes because especially once people get on both a basal and bolus insulin, it gets a little bit more complicated, and sometimes we might attempt to make changes, but then the patient comes back and didn't really fully understand that and hasn't actually implemented the changes. Insurance coverage continues to be a big issue, just the cost of some of the newer medications. We try to make the changes, think the insurance is going to cover it or do the prior auths, and then we're just waiting, and then the patient comes back and was never able to obtain the medication. So I think, the combination of all those things, and then also just the chronic disease burden on patients that were often not just adjusting the diabetes medications, but also adjusting blood pressure and statins and addressing pain and depression and all these issues in one visit. So they, just get confused and overwhelmed and sometimes kind of give up at that point.
Thank you, Dr. McVie, for that information. Now, I was reviewing some literature, and some of the factors that they mentioned in regards to non-adherence, for instance, is denial of disease severity. Have you seen anything in regards to patients who believe that diabetes is, or patients who do not understand the complications of the disease, and how do you address this denial?
Yeah, I would say that's maybe a smaller percentage, but it is definitely there. And I think just trying to maybe focus on the small changes that they can do, and not using scare tactics, because I think that's been shown to not be effective, but really working with them around shared decision making and trying to make it something that is treatment plans that are relevant to the patient's life, that they can actually do, that aren't overwhelming, but that move them in the right direction. The BHCs can be, the behavioral health consultants also are really helpful in those cases.
Okay, great. And the other issue that you mentioned, which is very important, is the number of medications that a patient may be on, and specifically if the patient has a cardiovascular disease or any complication or any other chronic disease that is affecting the patient. Who is responsible for all this education, Dr. McVie, at the Rio, specifically in regards to the number of medications, the possible side effects, and following up on the patient? Is the pharmacist the person, the clinician, or both?
It's really a combination of different members of the team. So the medical providers, of course, are responsible for doing that as they prescribe medications, and hopefully are attuned to deprescribing when appropriate. But also the clinical pharmacists, the actual pharmacy pharmacists, the RN care coordinators, the MAs when they do the med intakes. Really, it's trying to get everybody to work together to constantly reinforce that. And then also we have our wellness programming. So certainly not all of our patients attend that, but when we can get people to go to our wellness programming, they actually spend quite a bit of time between the wellness team and the clinical pharmacists go to those meetings as well, in more education around the medications.
Great, thank you. Anybody else who would like to chime in on clinical inertia or medication non-adherence? All right, so let's move on, and let's talk a little bit about some programs to address risk factors. We mentioned some in the beginning of the conversation, some of the modifiable risk factors: obesity, diet, physical activity, smoking, alcohol use, and mental health is also another modifiable risk factor, and other related conditions like cholesterol and hypertension. There are several programs at different levels. There are community level interventions. There are provider-oriented interventions. You can also have a conversation with the family and have family-specific intervention and any educational interventions, such as materials that you can use to educate your patients, fact sheets or videos or pamphlets or any kind of educational material that you can use. I would like to hear any I would like to hear from all of you in regards to the programs that you have at the community level, for instance, what you are doing. I understand that some are diet programs or some exercise programs, and some of you are working with some community organizations. And let's talk a little bit about these community interventions. Anyone?
So this is Joy. I've mentioned on these calls before, but we have a medical weight management program, and really the idea with that is to use what's known as the weight first approach to address weight before people develop chronic diseases related to their weight. And so we have a 12-week program. People get 12 intensive wellness visits in a group setting, and then have coexisting with that 6 medical visits, so one every 2 weeks for the 12 weeks. And we do use medications for weight management in addition with the intensive wellness and lifestyle intervention, really with the idea of preventing diabetes or better controlling it, trying to decrease the number of medications people are on.
Thank you, Joy. How do you identify the patients or the potential participants for the Weight First program?
So it's a combination of provider referrals. So all the providers are aware of the program and can refer patients. And then also we have flyers, and it's part of our general wellness calendar that we give out to patients in the clinic. We do have a huge waiting list. We do 3 cohorts a year, and each cohort we usually have 5 to 6 classes. But before each cohort opens, the month before it, we usually already have about at least like 80 to 100 people on our waiting list, and we just haven't been able to do enough classes to work down that backlog. So a lot of times the patients who are most proactive themselves about calling our coordinator for the program and getting themselves kind of moved up that list by being the squeaky wheel, the reality, those are the patients that are most likely to actually get into the program.
Mm-hmm. Is there any age limitation, Joy, in regards to the patient cannot be younger than 18 or older than 65, for instance? Or anybody can be part of this?
So it really is focused on adults right now, so 18 and older, but we don't have an upper age limit. So I think we've had some people maybe in their low 70s. I don't think we've had people older than that, but we haven't tried to limit that.
Okay. Thank you so much for that. Anybody else, any other community intervention that you would like to share with the group?
So basically, this is Trishna with Tri-Cities. So we do have a wellness boot camp that we put on usually on a monthly basis or every couple of months. Our attendance is low at this point. We're trying to motivate more people to be part of it. But the way we grasp the patients is through talking to them when our wellness team talks to them, through provider referrals. We have posters if anybody's interested in joining the boot camp. So what we do is we put on 3 classes, and in each class we go through a succession of teaching as well as hands-on. And something neat that we do is we actually take the patient's blood sugars prior to a brisk walk, a 10-15 minute walk, and then we retest them after the walk, and we show them how most of the time their blood sugars will drop at that point. And it kind of lets them know that yes, exercise does work, and it kind of motivates them to make sure to continue exercising because they do actually see the difference right there. And then another thing we do is we take a walk over to our local grocery store. We have our registered dietitians go through the aisles with them and point out certain foods and how to read the labels. So that helps quite a bit as well with our diabetes patients because they can see it. A lot of them don't know about how to read labels or what the hidden factors are in the labels. So we do hands-on so the patients can actually grasp the fact that, okay, yeah, I see it in front of me and I believe it. So those are a couple of things that we do through our boot camp, and that's our outreach with the community.
All right, thank you. That's great. And you know the brisk walk idea and checking glucose levels. I believe that that's something that the patients can take or can understand easily, and how exercise, for instance, is very important to address some of the symptoms of the disease. And some and the other thing is the idea of getting patients to better understand the labels, you know, and the nutrition labels, which is another big issue in primary care that is also linked to health literacy. That's fantastic. Anybody else? Any other community intervention that you would like to mention? What about collaborations with, for instance, for those who are public housing primary care? Are you working with public housing agencies, for instance, and developing some either health fairs or visits to the public housing developments, or those serving the homeless population? If there is any intervention that you are doing with homeless organizations in your community?
This is Andrew again with Tri-City Health Center, and I want to speak to that just a little bit. Again, with the Health Homes program, the concentration really is working on folks who are literally homeless. And with that being said, the majority of our patients are literally homeless. So what we do is we have all of our case managers in our HHP program. They are all certified to do assessments, which in our county you have to go through a whole system and through an assessment. So we make sure that every patient that comes through our caseload is assessed for housing, and then we work with our local housing agency to make sure that we get all the documentation and everything needed for these patients, so that if their number is called or they are moved up the list, they can be placed immediately instead of having a lag or a wait. We also do a lot of kind of just housing work with patients looking for alternatives. We have a patient right now who's, you know, his diabetes is fairly managed, but he has some other issues going on as well. And he was on the verge of being kicked out of his sister's house, but we've been working with the family to make sure that he stays there as long as he could until permanent housing is found for him otherwise. So it's something that we realized a while ago here at our clinic, and we've really taken great strides to make sure that we can incorporate housing with our folks who have chronic management for diabetes and other health conditions.
Excellent. And you know, you touched on another of the programs. You are working with a family, and then that's part of the family-specific intervention. That's great. Now, just a very quick question or follow-up question: do you offer, or does Tri-City offer transitional housing?
So we don't offer transitional housing here at Tri-City Health Center.
Okay, you don't. Okay.
But we do, but we are partnered with our community housing agency.
Yes.
So they're the ones that, and the way, unless you guys are out here in the east, some of you maybe in the East Bay, the way that we do our housing, the coordinated entry, and a lot of counties have moved that way. It's a little challenging. So getting someone into housing out here is just, yeah, it's a long waiting list.
Okay. Okay. Great. Thank you. Um, Anybody else? Any other program, either at the community level or any educational interventions that you would like to share with the group? Okay, I have a very quick question, and this is a follow-up on education. One of the things that we discussed with HRSA the other day, we had a conference call to see and to briefly discuss all these conversations that we're having with community health centers and lookalikes. One of the issues that somebody mentioned and brought up during the conversation was in regards to education. We were talking about who is providing all the or who is educating the patient, and we were talking about all the providers and the outreach workers. And one of the things that was mentioned in the conversation was the use of diabetes educators. Does anybody have a certified diabetes educator?
Yes, Tri-Cities does.
Okay.
We have a certified diabetes educator on the wellness team.
Okay,
And
this
she
is
hosts most of our boot camps as well as counsel patients over the phone from her panel. And she deals with the patients who have the higher A1C levels, so we kind of target it a little more just because of their A1C levels.
okay.
So she goes into more details about the medications and how to take them, and more education on how the medications affect certain parts of the body and which medications are more effective for depending if they have any comorbidities or any other diseases associated as well. So she goes into more detail, and she hosts our classes. So the boot camp classes, so they're able to ask more questions, and she's able to go into more details about it.
Excellent. That is great because that's part of the activity and if I'm not mistaken, when they heard from this participant about diabetes educator, they paid a lot of attention to the need, I guess, of having more people who somehow have a better understanding of the disease and somehow is licensed to provide that education to patients. It's just another piece of the puzzle, I guess, that we can consider. Now, in regards to materials, educational materials, is that something that you guys get from federal agencies, or do you work with, for instance, your state or your local Department of Health? What kind of educational materials do you use?
So this is Tri-Cities again, Trishna. We get most of our education material from our drug reps, and then we also print some of our own posters and make it a little bit more animated so they can understand it. We have the drug reps that give us basically like road maps with pamphlets showing how to get to better health. It's more animated, so I think if there is some sort of a barrier understanding the literature and the words, that this animated maps and pictures kind of help the process.
Okay. Thank you for that. All right. let's move on and just briefly talk a little bit about behavioral change interventions. This is another big area. We were discussing some of the main issues in regards to non-adherence, and somehow these behavioral change interventions are linked to non-adherence. There are several ways that you can discuss these diabetes symptoms and issues with the patients, despite of the determinants that the patient is experiencing, or despite the complications, and this requires sometimes the work of not only the primary care providers, but the mental health providers. And I would like to just briefly talk about some of the interventions that they're used. Like, for instance, are you working with your behavioral health team to address some of these issues, for instance?
Yes, Tri-Cities does. We actually also have our behavioral health one part of our diabetes boot camp, where they come in and they talk to the patients on how to connect mental health, or how to accept the disease. And then we do refer patients who find themselves unable to handle the fact that they have diabetes, and it's just a block for them to change their lifestyle. We do refer them to our behavioral health to see if there's some other issues that are underlying, like personal issues that are barriers to help them get to a better health state. Because if they have personal issues, they're really not worried about their health as much, because they're dealing with all these other issues. So if we recognize that, we are referring them to behavioral health. And we do have behavioral health for those patients who do join our boot camp. They do present a portion of our boot camp to help them associate that, if you do recognize that they may have some barriers, and get some help.
Great. Thank you so much. That's wonderful. Silkia, any behavioral intervention in Puerto Rico? How are you working with the behavioral team to address diabetes?
Well, in diabetes, every patient here has a PHQ-9, at least in the first visit of the year. It is positive. They are referred to our mental health clinic. We have like 8 psychologists and 1 psychiatrist here to give service. But all diabetic patients that have A1C greater than 8, they are referred automatically to the mental health clinic.
Okay, and that is regardless of any complications or anything, right? Do you use the A1C greater than 8 as a tool to refer patient to behavioral?
All our diabetic patients is part of our protocol. They go at least twice a year to their mental health care provider here. It's part of our protocol. They have to go there, no matter if they're controlled or not.
Okay, excellent. Anybody else? Any other behavioral intervention?
This is Joy. So what we do is we run a report that integrates our daily schedule with people who have an A1C over 9, and the behavioral health consultants will go around and automatically see those patients either before or after the medical provider, trying to capture them when they're there.
Okay. Now,
we do Puerto Rico. We walk with the patient to the mental health clinic after they see the PCP here.
Excellent. Thank you so much. Now, question for the clinicians: do you do any kind of motivational interviewing for your patients when you have a patient with diabetes or any other chronic disease in general? Anything that you use as a tool for motivational interviewing?
This is Joy. Yeah, I mean, definitely trying to integrate that into all my interactions with patients, whether it's around lifestyle or medication adherence. I think I'm not nearly as skilled at it as our behavioral health consultants, but I'm constantly trying to learn from them and to improve my skills.
Okay.
Mm-hmm.
Excellent. That is, as I mentioned in the beginning of the conversation, probably we are going to host a webinar on motivational interviewing, specifically for a patient with diabetes. That is another topic that we've been discussing with the American Diabetes Association. And they have training. The name of this training is Diabetes is Primary. This is a 1-day training. But we are working with the other agencies providing training and technical assistance to community health centers to see how we can deliver this training, but this is one of the sessions, and probably we are going to have someone from the American Diabetes Association to discuss behavioral change interventions and motivational interviewing. I believe that there is a need of having additional information and definitely that is something that we are planning to include in the next months. Anybody else in doing any behavioral change interventions, any kind of services in this area for your diabetic patients? All right, and the last issue that I would like to briefly discuss with you is I would like to hear from all of you, if possible, if there is if you have seen a link between patients with diabetes and any behavioral disorder or mental health disorder like depression or an anxiety disorder, or anything that is related to stress due to the disease. We've been talking about the referral of behavioral health and behavioral health clinicians, but what is your opinion in regards to the probably the incidence and prevalence of mental health disorders in diabetic patients? Anyone?
So this is Joyce. So we are using this tool called Relevant to pull, or we're able to pull a registry of our patients with an A1C greater than 9. And as we work through those lists, we definitely see that the overall diabetes population might not be any different, but people who have the A1C greater than 9 definitely have a greater burden of coexisting behavioral health concerns. And so, for multiple different reasons, but that is one of the strategies we've recognized has to be really primary, is to address those issues as well as purely the diabetes issues. Okay. And Puerto Rico, Silke, you mentioned that if the patient has a ACE greater than 8, you automatically refer patients, and you use some of the diagnostic tools. What is the approach for patients who probably are not diabetic patients but have a chronic disease? How do you link these patients to mental health interventions?
Well, in one mental health system, the majority of our patients have a problem with mood disorder, anxiety, or depression. I'm talking about the 65% of our patients have mental health issues. So annually, at least they go once a year to see the psychologist. We use our instrument is the PHQ-9. That's the one we use. But if the physician found that the patient is depressed, even the tool is negative, he will refer the patient to the mental health clinic.
Okay.
But mental health is an issue here in Puerto Rico, a big issue.
And what is the percentage again, Silke? 63 or 65%?
Yes.
Okay. Wow, that's a high. That's a high.
Yeah, it's a high, and those are the ones who are diagnostic.
Okay. Any other who would like to chime in on this particular issue? Great. Well, one of the things that I would like to do, and you are going to receive an email from me, is I am planning, since we are working with some organizations and trying to improve all the calls and all the activities that we are doing on diabetes control and prevention. There is a training that on some ideas that we would like to probably get feedback from all of you. And probably by next week, I'm gonna send you some materials and see whether you believe that this is something that is doable, and if there are different areas, or different kind of trainings like webinars or live sessions that I would like to share with you, and I would really, really appreciate if you can provide me some kind of feedback. As I mentioned, there is the opportunity to provide some regional trainings on diabetes. We are working again with the American Diabetes Association, trying not to do a national event because it's sometimes travel expenses and some other time issues. Probably a national is not the best way to go on this particular training. But we are discussing the possibility of doing some kind of regional training. So I'm going to, as soon as I get additional information on where the trainings are going to take place, I will also share that information with you. So any last issue that you would like to discuss?
This is Trishna with Tri-Cities. I just wanted to add one thing. So also another way to reach out to our diabetic population is we actually run the A1Cs in the clinic when the patient's here if we realize they haven't had one when they were supposed to. I don't know if a lot of facilities do that, but so we capture it. Instead of giving them an order to go to the lab, we're not sure if they'll even make it there or if they'll procrastinate. We actually run the A1C while the patient is here. And if their A1C is higher than 9 or 8, we go ahead and we counsel them right here with our wellness team after the provider goes in and sees them.
Okay.
So that's another thing we could capture right away is when they're in the clinic. We just run the A1Cs, and we have the capability to do that in our clinic at Tri-City.
Excellent. Now, I'm sorry, follow up on that one. Do you run the test only on diabetic patients or all your adult patients in general?
So we definitely run it on our diabetic patients as a routine.
Okay.
But if they've never had one run and they are risk factors for it, they are the provider will decide that's at their discretion to run the A1Cs, and the MAs do it before they see the provider after the provider reviews the file.
Okay.
And I just want to add something to that as well too. On the clinical piece there for patients who aren't diabetic. For most new patients, that's actually part of the panel that we will run. So that's how we capture a lot of our newer diabetic patients is through that initial screening. So when a patient comes in and they've never been seen at Tri-City Health Center, that's usually something that is run that day.
Mm-hmm. Mm-hmm.
And we've actually even done so. one of the successes that we've done in the past, a long time ago, when we've had specialty clinics, so let's say like a men's drop-in clinic or a family planning men's clinic, we've actually offered A1Cs to those populations as well, and we've captured diabetic patients that way because they wouldn't be receiving health care for any other reason other than that specific population-specific health reason. So we felt that it was important to really integrate as much as we could into one visit so that way we can see what's going on with them real time.
Excellent. That's a great idea. Have you seen any pattern in regard, or have you compared your data with, for instance, county data and see how Tri-City is doing compared to your county in general, or your state in general, specifically in regards to uncontrolled diabetes, with all these activities that you're doing? I mean, I'm just curious, just to know how you are doing compared to probably the state level data that you can get or the county level data that you can get.
This is Trishna at Tri-Cities. I really can't answer that question at this point because I'm not sure about that.
Okay, no, that's.
But I know we do run a lot of data, and we are they do compare, but I'm not sure if this is particularly one. I'm sure it is. I just haven't seen the data as of yet.
That's fair. That's fair.
And I'm new to the team as well, but I'm sure that we do at some level.
The only reason why I'm asking you is because if we have some county level data on our website, if you go to our website, nchph.org, there is a section where we have some interactive maps, and we have data from that we have gotten from UDS, and county level data from the National Center for Health Statistics. So you can see, I mean, I am quite sure that the quality assurance director or the clinical team may be interested in seeing how you guys are doing and what you can do to improve those numbers. I mean, that's another tool that you can find on our website.
Thank you for that information.
All right. Well, thank you so much for participating. Tri-City, I really appreciate your input and feedback today. So once again, you're gonna hear from me next week. I'm gonna share some of the materials that we have collected from these agencies, and if you can provide some feedback, that would be great. And then I keep you posted on any training or anything that we are planning to do in the next couple of weeks. Thank you so much for participating in this call. I appreciate your feedback and your best practices and the support for this group. And all of you have a great afternoon and good morning for you guys on the West Coast.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.